would just switch her diagnosis. She doesn't have Behcet's.
Yes, Michelle, we agree with that. And that's the interesting thing about clinical problem solving, which is the theme of this conference, that sometimes even if you're not right on the diagnosis of the problem, the treatment may work out beautifully for the patient. So this is one of the illustrative points which we wanted to be part of this theme. And we have got a small input coming in from a student here.
Okay.
Good morning, ma'am. Ma'am, there was an article which you had sent to us for review. In that, quoting directly from it, the brain lesions or the neural lesions which we see are different in MS and NBD in a very, there's not much difference, but it's still notable. Like optic neuritis or the sensory symptoms, dysarthria, ataxia, they are more common in MS and more like rare in NBD. And even the lesions of the brainstem, they are commonly extending into the basal ganglia and diencephalic structures for NBD, which is seen in our patient. The MRI and the CT scan images, there is extension of the lesions into the basal ganglia or into the, the brainstem atrophy is very clearly seen. So that is more supportive for NBD than MS. I feel that way.
No, I didn't say she had MS. I said it was sarcoid. That's why I didn't. I don't think she has MS. It's sarcoid.
Okay, sorry.
So she doesn't. The reason she doesn't have it's not Behcet's is because she doesn't meet. She doesn't have the diagnostic criteria. She doesn't meet criteria. And one of the things about sarcoid is you can have neurosarcoid without having lung involvement and some of the other extra cranial involvement that you have. And then again, like I said, my location where we are in Philadelphia, we have frequently we see people with sarcoid. And again, I don't know, you're in India. I don't know the epidemiology. That's why I showed you the best I could of the demographics. India's not on the map. I don't know what the incidence is there, and I don't know what the incidence of sarcoid is in India either. So you have to look at your inpatient populations.
Hello, Rakesh. Yeah. This is Kaushik here. Could I comment something?
Yeah, sure. Please.
Hello to all.
Kaushik is a neurologist, Michele.
Yes.
And the others online. Hi, just to introduce Kaushik, he's a neurologist, online neurologist. So he would like to talk a little bit about the neurology part of this patient. Yeah.
Yes, ma'am. Ma'am, I joined in late. I'm so sorry, but I've gone through your slides and your comments. I totally agree with what you're saying. Just that the input from an Indian perspective, what I wanted to add, ma'am, is that sometimes what we see is we have difficulty in following up these cases to actually see how they evolve into. For example, we say about sarcoid or a neurosarcoidosis, maybe we are seeing them at a time where there is a predominant neurological involvement with the lung involvement or other signs, or the, we are still not seeing them. We are not seeing them. So when we see them early, we put them in a bracket of possible Neurobehcets or something. And then these patients, either we are lost to follow up, or maybe, we try to get them back. And investigating them is also a big challenge, ma'am. There are a lot of cost constraints in this. For example, even if we are going to look at neurosarcoid, if we have to run the entire battery of sarcoidosis, including a HRCT and probably a biopsy, those are going to be difficult with us. So sometimes we just have to work with the investigations that we have.
And well, I'm going to interrupt you for a second, because you don't have to do the HRCT on her, because some of these patients, they don't have pulmonary involvement. I mean, the things to do that are serum calcium, because if a calcium is elevated, an ACE level, if you have that, but you don't have to go and, I mean, vitamin D levels are expensive, but maybe just a calcium and an ACE level.
I totally agree with that, ma'am. Maybe those baseline investigations, I'm sure they would be doing it. But sometimes we might end up treating these patients with whatever investigations we have, and we might not have the access to the plethora of other investigations. But you rightly said, ma'am, maybe it doesn't fit into the criteria of Behcet's, or at least Neurobehcet's, and we could entertain the diagnosis of sarcoid. But beautifully, as you told rightly, ma'am, if the treatment is similar, and that is why probably she had a response, the diagnosis could change, but still with the access to whatever investigations and management options we have, this is sometimes the best that we can do.
We did great. Don't say the best you could do.
I'm just saying,
You have a
just that we
patient who
didn't
was
make
in very bad shape. He's leading a normal, good life. So you did very well.
yes.
So
Thank you.
thanks, Kaushik. Yeah, Michelle, I mean, we would like to end this on a happy note. And just before, ending this session, there's a very interesting thing about sarcoid that, before sarcoid happened, people thought it was all tuberculosis. And even as we look at the, the morphology and the evolution, it appears, I mean, that's the theory, as if, the mycobacteria has kind of started expressing itself in a different way, where we are not able to see the original antigen. And that's a kind of a theory which goes for many autoimmune diseases, where we think that, we call them autoimmune, but it's probably that we are not able to see the antigen. And sarcoid is one of those where it behaves a lot like, mycobacteria. So if you look at it from the Indian perspective, we see very less sarcoid. And because we are still full of mycobacteria. I mean, wherever you come to India and you see, most of us see mycobacteria a lot, but sarcoid is very less common, and it appears as if the antigen is just slowly taking time to mutate itself to a certain degree in our population, which will kind of, make it invisible. So that's just a theory of sarcoid, which I thought might be a bit pertinent here. So Michelle, can we move to the next person, Binod, because he is also his part.
Please, yes, it was my pleasure. Thank you very much for having me. This was wonderful, and it was good. We had a lively discussion.
We are looking forward to you coming over. I know the pandemic, that's one of the scares, that if you come and there's a lockdown, you'll be locked in here. But I mean, you can always come into our campus anytime, and it will be great. So that'll be your second India visit. Yeah.
Okay. Thank you. Thank you very much.
Thank you, ma'am,
thank
for the wonderful
you. Thank
discussion.
you. Yeah. Is there Dr. Sadhana online? Would you like to give an input? Yes. Over to Dr. Sadhana.
Yeah, good morning, everybody, and good evening, Dr. Michele. I think you very aptly said that calcium and ACE levels are something which are very much feasible in our setup. And I think those are two things probably which I also felt could have been done, but then Dr. Rakesh knows better because he had been handling and he knew the the whole background of the patient. I did see some of the sarcoid in liver way back a decade ago, I think. And that had presented at hepatitis. So they had hypercalcemia, and we did go for biopsy. And as you very correctly pointed out, we had been often missing sarcoid for tuberculosis for over the ages. Probably if we have a good HP, maybe we'll come and we'll have a better numbers to look for.
Yeah, thanks, Professor Sadhana.
Yeah.
That was a very
Dr.
valuable input.
Yeah.
We have to up our game and use more resources to kind of get the sarcoid in, which is kindly a little bit elusive because of the mycobacteria, which is much more common. So yes, from a clinician's perspective, I think we have always got to be on the watch out. And so thanks again, Michelle.
Thank you.
And I hope,
Thank you.
Yeah. So thanks a lot. So
okay. So have a good day, and I'll have a good night. Thank you.
Yeah. It was really good to have you here. So let's move on to Professor Vinod Dakal. He is currently in Medical College of Wisconsin. And yes, Dr. Ashita will introduce him in detail. Yeah.
Thank you, Dr. Michele. We are honored to have you, Dr. Binod. He's a associate professor of medicine at the Medical College of Wisconsin, Division of Hematology, specializing in multiple myeloma and plasma cell disorders. He has also won several awards during his fellowship, which include the American Society of Clinical Oncology and Outstanding Medical School Teacher Award, and several other awards. Thank you so much, sir, for having us. I would also call upon stage our next speaker, Dr. Rashmita, who is our final year postgraduate, who would be talking upon a nice, interesting case on multiple myeloma. I would also call upon stage Associate Professor Praveen Naik, who is the moderator for this session. Rashmita, please come on to the stage.
Yeah, Rashmita will just give us a small brief overview before she goes into the detail, because we do not want to hold Dr. Vinod Dhakal for long. So we want him to speak, and Rashmita will just give a small brief overview of the case. And we've already shared the case with everyone. So I think most of us, the audience is primed on the case as well. So just a small introduction from Rashmita. Yeah.
Good morning, everyone. I heartily welcome every one of you for the CME on clinical problem solving. Today, I'm here to give over my voice on about a 56-year-old female who presented to us with pericardial effusion, which is an unusual presentation of multiple myeloma. So to begin with, she's a 56-year-old female presented to our OPD one year back with complaints of pedal edema, shortness of